This material is for reference and educational purposes only. SimKit, its authors, and associates assume no responsibility for the utilization of any knowledge, materials, or techniques shown or described, nor do SimKit, its authors, or associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedure and processes in each individual patient. Hello, everybody, and welcome back to the SimKit podcast. I am here today with a special guest, actually a special returning guest, a friend to me and the podcast, Dr. Andrew Phillips. Dr. Phillips, he is an ED intensivist, Associate Medical Director for the ICUs, where he works the founding medical director for his hospital's ECMO program. Very nice done. Nicely done, sir. And, the list just keeps going on and on. Women's Hospital ICU, the founder and editor-in-chief of EM Coach, which is a very popular board review suite. Dr. Phillips, thank you for what you do for our specialty, for the combined specialties of EM, ICU, and thank you for joining us today.
A pleasure. I'm excited to be back. Thanks for having me again.
Yeah.
It's a great topic.
Yeah. It's a little bit of a spin-off. If people, haven't heard our prior podcast together, it was on Make It Stop, the vent alarms and how to address them. We're going to take a little bit of a different approach, maybe sort of similar topics in some regard, but very, very specific and very scary. Today, we're talking about intubating the asthmatic patient. Now, throughout my training and my career, I have always been taught that intubating asthmatics is varying degrees of failure. And I do want to highlight that if you get nothing else from this podcast, we're going to talk about how to sort of mitigate these risks. If you get nothing else out of this podcast, intubating patients with a severe asthma exacerbation should not be taken lightly. It is very challenging not only to do, but after you put the laryngoscope down and you high-five your colleagues, you're still in for a world of hurt in many ways. They are very challenging to handle post-RSI or DSI. Now, Andrew, before we get into why that is, why this is tough, and, of course, how to make it easier, I want to ask you, what is your approach to sort of staving off an intubation in a patient with status asthmaticus?
Great question. And you're right, a lot up front to try to stave this off. First is recognizing early that they are in status asthmaticus and where you are going with things. Recognizing one of the couple most important pieces of history. You don't get much, right? So right off the bat, I want to know, have they ever been intubated before for asthma? And did this come on over just a few hours, or has this been lingering and getting worse over a few days to a week? Because if it's been a few hours, I'm probably going to be able to turn things around. If it's been getting worse and worse over several days to a week, I'm screwed. It's just in my head already, I'm thinking, go ahead and get the intubation stuff prepped, and that's the direction that we're headed. Same thing if they've been intubated before for asthma. Just start preparing yourself and your staff for when we have to intubate. So everyone, same thing sometimes that like people talk about for a crike, right? You don't say if, you say when. So people go ahead and make that transition because it is going to be a moment of a lot of activity. We'll say
Trepidation.
when you get to that point. Yes. So hitting up front, understanding where they're going with things so that you don't waste time. The magnesium, the albuterol, and it's not going to be the 2.5 milligrams. Oh, let's put that in neb. You start off right off the bat with, I go ahead and start with 20 milligrams per hour of albuterol and just toss that in. Because otherwise, the RT is having to come and do more and reset. Just load that up, turn it on high on the wall, right? The next thing is magnesium. Now, the key to magnesium, often people get this wrong. It's 2 grams, but it's not the standard magnesium. Be careful when you're ordering it and when your nurses or RT, whoever manages that is giving it. It's not the standard 1 gram over an hour. It's got to be over 20 minutes. And that's the whole key to it because you have to push it not push it, but advance it quickly in order to get the bronchodilatory effect.
Sure.
Now, one of the things that comes from that is hypotension because it's bronchodilatory and it's also going to have some vasodilatory effects. In these patients, it doesn't matter. And sometimes people will talk about, caution with magnesium because of the hypotension. And it's true. It does reduce the blood pressure some. But the reality is these patients, I don't think I've ever seen one of these patients with a blood pressure less than 160, 170 systolic because they're struggling, right?
Their catechols are through the roof. Yeah.
The surge is there, so it's a non-issue in this population. So we've got high dose rapid albuterol and the magnesium. And then, you talk about terbutaline versus epi. And you and I were speaking just a moment ago about this. I did a little dive in this because I've never used terbutaline. I use epi, and it's 0.3 to 0.5 sub-Q, by the way. You can go up to 3 times on the epi. And I never used terbutaline. I'd certainly heard of it in all the literature and all the talks. And one of the studies I ran into said that on a survey, 98% of physicians had rarely or never used terbutaline, which was interesting to me. So, okay, I'm in the majority of the crowd here in my practice pattern to use epi instead. But I couldn't actually nail down a single RCT or solid article as to why we should be using epi instead of terbutaline. And to the contrary, I saw not the strongest of articles, but observational from the early 80s. It was like in 1983, 1984, which admittedly I still feel like was not that long ago, but it's pretty old, showing that maybe terbutaline was better. So I like to be able to give your listeners a little more precise answers, but I couldn't really find anything that strong for why terbutaline continues to be in the literature and for us to, in the lessons, but I don't know why we moved away from it. So it's very reasonable to be using terbutaline. You get to use it up to 3 times as well. Give it a try if your shop has it. The epi is a perfectly fine alternative. It's just another one of the adjunct agents.
Okay, perfect. That's excellent. And to sort of summarize and then break down, I'm going to ask you a couple more sort of high hit points. So let's go over that beta agonist first. Albuterol. Basically, in a nebulizer, you're filling the chamber, right? If you're putting 20 milligrams in, you're basically filling that reservoir, and you're putting it on like a quote-unquote non-rebreather type mask rather than right. Do you bother with breath actuation in this state when someone's, peri-intubation, peri-arrest from asthma?
Yeah, it's just continuous.
Continuous, perfect. And then the magnesium, that's a great point. I believe from your pharmacy, there are different formulations in ours. I know we have the sort of slow infusion one and then the one that can be quote unquote push that can be given over 20 minutes. And you mentioned that is rapid and 2 grams, correct?
Correct.
Perfect. Okay. And
then I could add in there, sorry, it does not matter what the mag level is. Don't draw a mag level and wait for it to come back.
Right.
You give it.
Give it for sure. And then in terms of steroids, do you have a preference? Do you care? It's just kind of dealer's choice in steroid.
Great question. I haven't seen anything definitively showing one over another. I feel like a lot of people use Decadron, but I mean, some people use 125 of Ciamedrol because they're used to that for COPD. It's a steroid and it's a lot. Yeah,
fair. Steroid, a lot. And realistically, Andrew, in the time of medication efficacy, we're going to either be out of the woods or fully knee deep in it by the time that steroid is really doing anything for this crashing patient, right? Yeah.
Exactly. I was going to say that. Exactly that.
Yeah. And then finally, so it sounds like a terbutaline, if you're back in the 1980s, 1990s, or you just like that medicine and you still practice with it, you've maintained it, and it's like, okay, I'm bringing back Drope, I'm bringing back terbutaline, that or epinephrine. Is that fair? It's an either or circumstance?
Correct.
Similar mechanism of action. And now tell me about in your epi, how you're dosing that. It sounded like you're doing IM. Do you do a certain quantity of IM before you switch to a drip? Do you ever switch to a drip? How do you approach that in your practice?
Easy way to remember that is same dosing as for anaphylaxis, 0.3 to 0.5 milligrams.
Okay. And are you, do you convert to a drip ever, or are you thinking that you're using your 3 rounds and you're either in or out of it by that point?
3 rounds is what I've seen published, and I'm trying to remember if I've ever gotten to the 3rd round before we've already failed.
Yep.
I don't think I've gotten the 3rd round before. You're either making progress or not, but that's what's written. I mean, it's a pretty rare circumstance. I haven't had that many. Even doing ICU work as well. So there's certain areas of the country they have us more often. But yeah, it's up to 3 rounds. I have not seen anything specific to continuing the epinephrine. I don't think it'd be wrong,
sure.
Particularly if you're hypotensive. But that's what they say is 3 rounds.
Yeah, and in that vein, I sometimes think if these patients are transitioning to a vent and you secure their airway, they are their catechols that have been keeping them alive for the last 5 days are now left, and you do start to see, maybe the mag or whatever their hypotension onsetting. Obviously, for me, then your agent is an epi drip for sure.
Yep.
Cool.
Yeah.
And what's your dosing frequency again on the epi?
Q 20 minutes, which
Okay.
is why I tend not to get all the way to the third.
Yeah, right.
By the
If you're
time by the time
hemming
you're
and
30,
hawing for
40
an
minutes
hour,
in,
you're done.
yeah,
Hmm.
yep.
All right, and now to transition slightly, those are the medications. So to summarize for the audience, we are basically loading up a nebulizer, not breath actuated, just nebulizer reservoir full of beta agonist albuterol. Sometimes obviously we'll use some ipratropium with that as well. Adding to that magnesium, 2 grams given rapidly over 20 minutes. Steroid, dealer's choice, probably not going to get you out of the woods in time for these crashing asthma patients. Then you can use terbutaline or epinephrine. Epinephrine, 98%, high 90% of people are using that. So talking about that dosing, we are using sub-Q, dosing it the same dosing as you would use in an EpiPen, and Q 20 minutes.
I was just going to add, you don't have to do these one at a time and see if it works. If you see
Right.
them and they look bad, it is very appropriate to do all of this at once.
For sure. Yep. And I've seen that circumstance. And for me, when we didn't dive into this too hard, and I don't think there's an answer. When you see the nebulizer misting and you're seeing their breath and it's not affecting the movement of the neb, that's my sphincter gets really tight. I'm like, oh boy, this albuterol is not getting in there. That is a very tight chest, and then it's full court press. Obviously there are other indications, but that always makes me think of cases I've seen with that, and like, we're pericode. This is not going well, but that's a full court press, full kitchen sink. In someone that maybe isn't quite there, but still very ill, what are your thoughts on positive pressure? Is there anything that we can hang our hat on, any literature to support its use in a crashing asthmatic?
So, we use positive pressure, non-invasive positive pressure for a ton of conditions. And it tends to wind up being this kind of, well, before I intubate, let me try. It's not always the best option for patients who are not breathing well. And I'll give you an example. Something like 30 to 40% of those with pneumonia and ARDS will wind up intubated anyway. And so waiting for that to happen with ARDS and pneumonia from BiPAP or whatever to then intubating just kind of delays the inevitable and makes things worse. It's not a good indication for pneumonia. Great indication for, this is non-invasive positive pressure, for COPD and for CHF. Oddly enough, it's actually not that great of an indication for asthma, which is now what we're talking about, right? So a lot of times when we're talking about management or we're thinking about our patients and the pathology, asthma and COPD are relatively grouped together. It's a somewhat similar pathophysiology, not exact, but same ballpark. And now one of the differences, of course, is magnesium is not helpful in COPD. It is in asthma. And then non-invasive positive pressure ventilation. A lot of patients who wind up on NIPPV for asthma still wind up intubated. Just there's not as strong of evidence for it as for COPD. So I encourage people, it's great to try it, right? Crank it up to 100% FiO2. Maybe it'll help them with their fatigue a little bit. But when I put on the NIPPV, I, in my mind, am pre-oxygenating. I'm not putting that on as therapy. That's pre-oxygenation. And we're already pulling up the ketamine. And we hadn't gotten to the ketamine conversation yet and the medications. And it's certainly not one of those upfront like magnesium and such, except that sometimes these patients are, I'm going to back that up actually. Oftentimes, these patients are in tremendous distress and they can't breathe, right? I totally understand. I get it. There's a good reason to be agitated, and it's hard to get your IV, to try to get the mask on. They're fighting you, not intentionally. They just, let's face it, they're dying.
Right.
And so sometimes we will do the ketamine up front as well. We may not have totally gotten all these other medications in, but if we are unable to get a line, we're unable to get the mask on to do the albuterol. Now, this is one of those when you're given that ketamine, and this is full induction dose, you're pushing 100 milligrams, right? You're dissociating them. You got to be ready with your ET tube. You can have laryngospasm. You can have them, ketamine does not really cause respiratory depression, but there's still a lot of other aspects of what you're impacting them with the ketamine. So be prepared to intubate if you're doing that. And this all kind of happens at once. And I know that's a disorganized and not very not very eloquent description of how to handle these cases, but it's the ED. This is organized chaos. And all these medications, the albuterol, the magnesium, the terbutaline or epi, and frankly, the ketamine are all going to be going in more or less at the same time, which is why I always am stressed with board questions. They're like, which one do you do first? And I'm like, shoot, they're all going in, right? Like somebody grab
just
an
one
arm
syringe with everything, right? Yeah.
Exactly, right? We're just give these meds as fast as we can in reality. And so, for the non-invasive, think of it like you're pre-oxygenating. And hey, maybe the ketamine kicks in. Maybe you can help the work of breathing a little bit, but we're definitely pulling both at the same time, getting the ET tube out as we're putting the non-invasive on. And now you're talking non-invasive, it's a BiPAP or CPAP. Who knows? There's not great evidence for one versus another. Theoretically, maybe BiPAP would be helpful because you're trying to get them to get those breaths. It's not an issue with the alveoli. But, I mean, I already mentioned that there's not great evidence for non-invasive one way or the other. There's certainly not any strong evidence for BiPAP versus CPAP.
Right. Yeah. No, that makes a lot of sense. And I think sort of backing up on that, I think about the BiPAP, BPAP versus a CPAP, in the flash pulmonary edema, the patient, these asthmatics are similar to that in my mind, in that this is like a type 1, it's a hypoxic respiratory failure. Oftentimes, like they're in that state because of agitation, because as you said, they're about to die. But the hypoxic, the type 1 respiratory failure, is more of the swinging, can't sit still, won't let you put a mask on, than the like really bad somnolent COPD hypercapnic respiratory failure. And so I could see how that sort of plays out similarly. Now, if you need to get the nebulizer mask on them, small aliquots of ketamine before moving toward RSI or DSI, which we'll get into in a moment, totally makes sense to me. In the benefit and non-benefit of different disease processes, very interesting to me and a little bit almost confusing, in that I can see, yes, flash pulmonary edema, you need the CPAP version, right? You need the PEEP basically to get the alveoli out of fluid, to get them stented open for that oxygenation side. I think of COPD as more probably beneficial to have that BPAP, BiPAP, where that they need to get that CO2 out, and that totally makes sense for me as well. Asthma, I honestly don't quite fully it seems more of a type 1, a hypoxic respiratory failure. When you're getting toward hypercapnia, that's bad, right? That's like a really bad situation to be in. So I can see how it's not at the alveolar level, so the CPAP isn't really affecting it. It's not really going to open up those bronchospastic, bronchi or bronchioli or wherever the spasm is happening. So it somewhat makes sense to me. But the pre-oxygenation, if somebody is coming in with that profound hypoxia and agitation, ketamine followed by some version of positive pressure seems like a reasonable way to go. Okay, so we've done it, right? We're doing kitchen sink. We're not going the way that the board review is. We're going to start with epi, and then we're going to do this, and then we're going to do everything's going together. We've done it all. They still look like garbage. Andrew, why should the ED physician respect intubating the asthmatic patient?
Yeah, so the asthmatic after you intubate is the patient who 10 or 15 minutes after you intubate has a code called on them after you've stepped away, things look okay, and you're going and seeing somebody else, and you're called back to that room that you just left thinking things were fine. It is the one that will catch you by surprise. It is the one where you have to be standing at the bedside, figuring out the vent settings for that particular patient that are going to change sometimes in the early periods, every 15, 20 minutes, maybe a little bit of adjusting to get things in a settled state. And, once they come to the ICU, fine, right? We have that kind of time. Those are the kind of patients that we have in the ICU. We're in the ED. If we spend all this time with this patient, there are 5 more reds on the board. And someone with that ESI 5 with the cough for 5 weeks wants to get seen. So, got to make sure your press getting scores are good. So you're hopping on over and then you get called back. The deal is in these patients is that you have to match their respiratory drive without matching the respiratory drive. What do I mean by that? When you have a primary respiratory failure, a hypoxic respiratory failure that you mentioned a moment ago, the pneumonia, right? They're breathing fast because they're hypoxic or just hypoxemic. But either way, they're hypoxemic, they're breathing fast. When you put them on the vent, you're not going to keep breathing 30 or 40 a minute for them. You don't necessarily need that because you're delivering a lot of oxygen. When you have someone who is breathing for metabolic reasons, so their oxygenation is okay. Had one recently with a pH of 6.8 after we gave 9 amps of bicarb. That was an exciting case. Yes, 6.8 after the 9 amps. So this patient was breathing in the 50s and had to tube this patient, and I had to set the rate at 35. I had to keep up because this is compensation for a metabolic cause. And the asthmatics are tricky because they are a pulmonary problem, but you kind of have to still keep them at a place where you are moving that oxygen, moving that CO2, but you can't let it just settle and rise because they're not able to get rid of the air as much as they were before. So, right, they take a breath in and then they can't get it out. So you have to adjust the ventilator with the pressures they already have internally, their intrinsic PEEP, but also deliver a breath on top of that. And it just, I don't know how deep you want to get into this. Sometimes you end up having to actually increase your PEEP in order to match their PEEP. So now you're talking about these high plateau pressures and relatively low tidal volumes. You have to really know what you're doing. You should, if you're not someone who intubates these folks very often, and if you don't intubate often, generally speaking, I would phone a friend for sure, because these can go bad. They pop a pneumo, and then you're really in a heap of hurt because you're down to one lung. And fixing that pneumo with a chest tube with these high pressures internally they already have are at a high risk for lung puncture, and then you've got a fistula, and it's anyway, I'm thinking of these cases in my mind while you're like, why don't you want to tube them? I'm just kind of thinking, how do I count the ways? That was just, it was rough. And so, yeah, that's why. The settings have to change. You have to do some fancy footwork sometimes, and they're just at such a high risk of ventilator-associated complications with these patients. That said, sometimes you have to, and It is what it is.
And so, yeah, I think your answer kind of speaks to obviously their complexity, and I could tell that you're holding back in some ways about a lot of the detailed ICU level, Starling curves, all the like craziness that might go into vent assessment and patient assessment. To summarize it, it's actually not necessarily, there's a gas exchange element to it, but not in the way that we're talking about like pulmonary edema and COPD. Those are a little bit cleaner in their own right. You put them on a vent, and that gas exchange is usually better. You can fix it, increase respiratory rate, increase tidal volume, whatever, FiO2, PEEP, pretty easy there, quote unquote easy. In the asthmatic, it's a movement of air issue, and they're dynamic in that they're responding to your therapies possibly, but also what you're putting in isn't always coming out, and the pressures that you're inducing by transitioning them to a positive pressure rather than using their own intrinsic negative pressure system is just fraught with problems, whether it be breath stacking to where they don't pull any tidal volume at all, or breath stacking plus really high pressures causing pneumothoraces. Seems like those are probably the two most feared elements of the asthmatic on a vent, but your reason why this is a 5-alarm fire or something to respect is they will look good and then they all of a sudden won't, and that is dynamic over the course of 10-15 minutes, and you have to be very facile with the vent to know what direction they're going and how to keep up with them best.
Yeah, absolutely. And I'll add to that, all the EDs I've ever worked in did not have fancy formal vents. They all had the transport vents. And the LTV is a very common one. And you just can't see. Those vents do not give you the information you need to manage, even if you have the world's greatest expert on asthma and intubation and all that. The vent doesn't give that person the information to make the proper adjustments. So the other thing I'd add is once you intubate these people, or when you're planning on it, you got to call upstairs and say that you need a real vent, so to speak, on the double.
ICU vent.
Mm-hmm.
Okay. So you can see stuff.
This is not the 20-year-old trauma patient who, has a head bleed, so you're intubating. Like this is a big deal. You got to see waveforms. You got to see if they're auto peeping and all that. And if I could take us back just a smidge, you mentioned they will look good and then they won't. One of the things I really want to bring up on that decision to intubate, and this catches people off guard, they will erroneously see an improving gas and a patient who's less agitated and think, oh, great, the medications are working, they're doing better. So let's say they have a gas like 755, a CO2 of 18, PO2 of, we'll say 60 or 55, whatever you want for the O2. They're breathing hard and they're getting that CO2 out, right? And then
CO2's out. Yep.
exactly. So then they start to kind of calm down, so to speak, and you get a repeat gas. You're 750 24 now from 18 on your CO2 and 55 or 60 on your oxygen. And you look at that and you think, okay, we're starting to normalize our pH. They're getting better. Wrong. They're not getting better. They're getting tired. They're no longer able to move that CO2 out. So what does a patient who's actually doing better look like? Their breathing is still moving that air. You're hearing opened lungs. These patients, you're going to have you have to listen to them. You will find that their air movement is less. They just won't have as many breath sounds. Remember as well, and I've seen this too, just because you don't hear wheezing doesn't mean they're not in status asthmaticus, right? Sometimes you don't hear wheezing. Let's say you heard wheezing initially, and now you get to this point, you see those gases, you're like, oh, I don't hear any wheezing. It must be better. No, they're not moving in the air. Right?
Yeah, the silent chest is the scary chest. Yeah.
Yes, and that's such everyone, I feel like most people, I can't say everyone, most people will make that mistake at least once. You have to think about it. It's a paradoxical thing that if they're wheezing less and their gas is better, you're in big trouble. And that sounds weird, even saying it out loud, but you got to stick that in your mind. Don't be reassured by an improving gas in an asthmatic patient.
Okay. And so it would be normal for them, right, as they are tachypnic, as they are to really blow down their CO2, for them to come in alkalotic, because, just like imagine myself just breathing through a straw, trying to run around the ER, take care of patients, breathing through a straw constantly. I could do that for a while. I could do that for maybe a couple hours. And then eventually my accessory muscles, I'm just going to fatigue. I'm not going to be able to keep up in that way. I'll probably initially blow down my CO2, breathing quickly to try to maintain myself. But as I tire, my CO2 will start to normalize, which is a bad sign. That's helpful information to sort of think about. I guess if you can, if someone were to ask you, Dr. Phillips, how do you know when you need to intubate the asthmatic? What's your answer to that question?
Half the time they'll tell you. Like they'll actually tell you.
Mm-hmm.
They're sitting on the BiPAP, and I'll just look them in the eye. We've already given them the MAG, the Epi, the albuterol, and you're just seeing them start to not breathe as fast. And I'll ask, are you getting tired?
Mm-hmm.
And they'll say, yeah.
Yeah.
Okay. It's
time to go.
It's time.
Yeah.
That's just, as obvious as that sounds, I just asked them, are you tired? And that's a key. The normalizing gas is an issue, and largely looking at what their work is. If you just see them not taking as big of breaths, but still being in distress, altered mental status, and that may be tricky if you've already given them the ketamine. But frankly, by the time you've given the ketamine, there are times, and I'm thinking of one actually relatively recently, gave the ketamine, dead non-invasive. I remember the ED doc called me, and he was like, she's actually kind of doing better. Like, I realized sending her upstairs on the BiPAP is that like the safest thing, but I don't really want to intubate her. What do you think about being this like quasi state? Like she's actually, the oxygenation's better and she's not as distressed. I think it actually worked. And sure enough, it did. We didn't have to intubate. We were on ketamine, kept it on a drip. So gave the 100 mg ketamine or induction dose. I don't remember the exact amount on that patient. and then had a drip, hung out on BiPAP for a couple days, and did okay.
Okay, and so you can kind of see that, huh? If you're looking at that patient and you just kitchen sink them, you have your reservoir full of albuterol, you've pushed the mag, you've given the steroid, and you've given your, maybe you're going to get through 1 to 2 rounds of your sub-Q epi. The person's work of breathing may slow, and then you're listening to the chest to see if the aeration's actually improved. If they're getting quieter, that's worse. If they're getting quieter and slowing, that's worse. If you have them on a non-invasive and you can get a semi-accurate tidal volume, is it staying the same or is it getting better? Is it increasing? That's kind of the branch point decision I'm seeing in my mind, is their tidal volume is not different. Their lungs are no more loud, and they are slowing down and looking more sleepy. That's one direction. The other is their tidal volumes seem to be increasing, either just subjectively or objectively. Their lungs sound clearer, and they're noting to you, I feel better. That seems to be your branch point decision. After the kitchen sink, which of those 2 paths is that patient taking?
And I'll say something else obvious. And one of the nice things about non-invasive, it'll tell you. You can actually look and see what their minute ventilation is.
Right.
You don't have to just listen. Use it. A lot of people aren't looking at the numbers. The numbers on your non-invasive are not just what your PEEP and your IPAP and EPAP and all that is. It'll tell you.
Actual tidal volumes, yeah. If those aren't getting better, if it's still 250, that's bad. Yeah. If we're moving toward, 350, 400, okay, we're making progress. All right.
Exactly. It'll tell you the respiratory rate. It'll tell you if there's spontaneous breaths or not. Use the information in front of you. The one other thing I want to say is the trickiest thing is for our rural colleagues. I work in rural ED, and that same patient who I just described who came upstairs, when we were in a big center, we had an ICU and an in-house intensivist 24/7 available for that patient. And the non-enviable position is that same patient in a single doc shop in rural town with an hour and a half transport, right? So for those patients, as painful as it is, I recommend that you give them a try. See where they go over 5, 6, 7 hours, because you don't want to intubate. It's going to be tough for the critical care transport as well if you intubate. Either way, right, it's a bad transport. So that's the patient you've got to hold on to. And I apologize, and that stinks, and I work there too, and I get it. That's the best route. See where they go. Give them a tincture of time. Let the steroids kind of settle in if they're kind of making it on the non-invasive positive pressure. Yeah. I just want to add that in.
No, that's a great point. And I think, it's important for us to think about all the practice environments we live in. It's probably worth that collective step back, because we mentioned very briefly in the beginning, and I think this is a great time to add that disclaimer that respecting intubating the asthmatic is the goal, not fearing intubating the asthmatic, because if you have fear in your mind, your heart, whatever, and you're going to stave it off, right? You're going to come up with other reasons. You're going to push yourself past the line in the sand, and you're going to intubate in a worse circumstance. So recognizing and respecting, but not allowing that to move your line in the sand. You need to know that it will be challenging, and because of that, be all hands on deck. All of your kitchen sink we've already talked about, but do not be afraid of it, but respect it in its own right. Keep that line in the sand. Make sure, like you said, not that if we need to intubate or if we need to crike, but when. Keep that mentality of we may get there, and that may be an inevitability for ourselves and this patient, but fearing it and pushing it off, it only puts you in a worse world of hurt.
I agree.
So into the meat of it, we've had our branch point. We've done our kitchen sink we've talked about. It's time. How do you go about intubating the status asthmaticus?
So most of these patients are going to be a DSI approach because you've already tried the ketamine with non-invasive. And you're in 2 different locations. Some of these patients, if you're behind the curve, they'll already start retaining CO2. Mm-hmm. Some of them are not quite there and they're still breathing it off, and that's going to change your pH. One of the questions was, bicarb. Well, if they're severely asthenic because they're retaining a lot of CO2, understand that this is a respiratory issue, not a metabolic issue. And the people, intensivists, have long histories of getting in very heated discussions.
Judicious, yeah, that was very political to say. Yep. Discussions, yeah. Fisticuffs sometimes.
Yes. About whether to give the bicarb when it's primarily respiratory, and there's not great evidence because there aren't a lot of these circumstances. So, it's either way. It's your comfort. You're not going wrong one way or the other. There are people on both sides that would defend either position.
Okay.
So hopefully you're ahead of the curve and they're not high on their CO2 at this point. They're going to be DSI if you've used this ketamine strategy, which is pretty common. I think most of the time people are trying that with the induction dose of the ketamine. They breathe on the non-invasive, and then you tube them, whether rock or succinylcholine. I'm one of the rock fans. It doesn't really matter. Understand that these patients should remain paralyzed. And I'll get into that in a second, but for that reason, I tend to use rocuronium to buy me a little time after the intubation to get settled. So one of the things we talked about just a moment ago with using the information from the non-invasive, whether it's CPAP or BiPAP, is it will tell you when they go apneic. I love non-invasive as a pre-oxygenation. By the way, turn up to 100%, obviously. But all of these machines, one way or another, our machines will turn a different color. They'll say timed or spontaneous. When the breath goes, there's a little button that'll show. All of them have, proprietary things, but it'll tell you. So you push your rock or your sucks, and instead of looking at, rock running 1.2 megakig and looking at the times, 45 seconds. No, you look at the machine, right?
Yeah.
So you go ahead and unstrap the bottom, you hold it on their face, and you and RT are together, you're watching. And as soon as you see, for me, right, this is no evidence, it's just Andrew's way of doing stuff. When I see two consecutive timed breaths, that's it. Pull. Some will wait 3, some will wait 1, but it'll tell you. It'll tell you when
once
they're
they
no
stop,
longer breathing.
they're not triggering.
Breathing
That's coming from the machine
exactly.
only. You're ready. Okay.
Yep. And so that reduces your downtime because it's been breathing for them the whole time. So make sure you get everything set up. If they're obese, you've got your ramp up there. Everything's ready to go. And as soon as they're timed, boop, you pop it in, and you're ready to go with your tube.
Perfect. Okay. So summarize that, we're going to try to get there before they're getting hypercarbic and acidotic. In this circumstance, they're going to come in most of the time alkalotic, having blown down all their CO2 as they try to breathe through the straw. When it's time to intubate, again, that line in the sand, maintain it, be strong, be ready, try to get to them before they're truly, really acidotic. If you use bicarb, go for it. There's not great evidence one way or the other. If you get 5 ICU docs in a room to argue about it, there'll be 25 different opinions. But ketamine is your agent. Recommending generally a DSI approach, delayed sequence intubation, giving ketamine and using positive pressure to maintain a respiration, to maintain oxygen delivery or transport as you move into that apneic time frame. It also gives you a really nice way to know, boom, that breath is no longer being pulled by the patient. We have moved to just actuated breaths or delivered breaths from the machine. They are now apneic. Let's move on to doing our actual tube. Rocuronium, succinylcholine, again, dealer's choice. As we get into managing the patient on the vent, you mentioned that these patients should probably be or should be paralyzed, so rock and its longer duration of action is a good agent. Sound right?
Sounds absolutely right. And the management on the vent, once they're there, honestly, is a whole other topic.
Yeah, let's do it. So let's pretend, we did it. Our sphincters are tight. We get the tube in. We high five for 25 seconds, 15 seconds, 10 seconds. You celebrate. And then now it's time to work. What are you doing to optimize that patient?
Yeah, so the key here is to avoid the breath stacking, which is why you don't want them to fight your vent. You want them to ride the vent. So they have to be deeply sedated, not just ketamine at this point, right? We're talking whether propofol in addition to ketamine, or I hate benzodiazepines because of delirium, but if you have to, you have to. But that's where the paralysis comes in. And it is not wrong. Initially, you're in the ED, especially if you're having to transfer patients, just paralyze them, put them on a vec drip, whatever you want. But that's why when I intubate, I'll use the rock because that buys me 30, 45 minutes that I'm not having to, hey, where's the vec drip after succinylcholine is wearing off 12 to 15 minutes later, right? It just gives me a little more time because things are still chaotic. So in terms of keeping them from breath stacking, you have to change your I to E ratio, your inspiratory to expiratory ratio. And that's, again, why you got to get a real vent, so to speak, not the little transport vents a lot of EDs have. It's a little tricky to understand because some of these vents, they pick a proprietary way of doing this. You can't just change your I to E ratio. You're either setting an I time or you're setting a max flow rate. And the I time makes, I think, the most intuitive sense. My inspiratory time is going to be half a second or a quarter of a second or whatever it is. And then when you multiply that out by your respiratory rate, that becomes a ratio, right?
Yeah, sure.
Your number of breaths. Because the rest of that time, if you're doing 30 breaths, you get 2 seconds for a breath per minute. If it's a half a second inspiration, it's 1.5 expiration, 1 to 4. Okay.
Yeah. Okay.
1 to 3. If it's 1.5 to the half, right? So the respiratory rate will impact your I to E ratio. So I time is one way to set it. The Dragers do it that way. Other ventilators will do by the max flow rate. So your Avias, for example, will do that. And you got to kind of work through the physiology here. If you are flowing at a higher pressure, then that means it's a faster rate of air going in. And if there's a faster rate of air going in, you can get your set tidal volume in faster, which means your I time is lower, which then changes your I to E ratio. So a higher flow rate is a lower I time, which is a bigger discrepancy in your I to E ratio, 1 to 4, 1 to 5, 1 to 6.
As much as that sounds kind of confusing, it actually, it's like, it's confusing, but it's not, right? So we have volume and pressure, settings on a vent collectively, right? This is not that different in its own right. You're determining how fast your breath goes in. You want a fast breath in and a lot of time to expire. That's our global goal. And you can set that depending on your vent and working with your ICU colleagues, either by, we're going to say that you have this much time to breathe in, or we're going to have you have this much or this high of a flow or pressure to breathe in. Both will make that breath short so that the expiration is long.
Yep.
Cool.
And you want to set that to an I to E, depending on how bad the patient is, at least 1 to 4, if not 1 to 6, 1 to 7. They don't tend to have to be as bad or as extensive as the COPDers, but it maybe as a general sense, start at 1 to 4, 1 to 5, and see where things go. Keep your respiratory rate relatively low, 14, 16. You may have to go even lower, 10-ish, but again, that tends to be COPDers. So 14-ish, 15, 16 should be about right, and keep them paralyzed. Because here's the key. If they start breathing and they have a high respiratory rate and the nurse says, hey, they're breathing too fast, and you're like, oh, we'll go down the respiratory rate. That's not going to do it, right? Breathing too fast is a propofol deficiency. And we talked a little bit about this last time. Just turning down the rate is not going to fix your problem. What you have set is a minimum rate on that vent. So that's why I just, particularly from the ED perspective, before they get settled in the ICU, put them down, paralyze them, sedate them deeply, let things settle, and let us, work through things with a tincture of time upstairs.
That makes sense. And so that's a really important final point in terms of keeping ourselves from this sort of world of hurt, the pneumothorax, the breath stacking to the point where they don't pull any tidal volume and they code. So once we have the person intubated, our sphincter tone stays high. We dial it up, actually. We were at 10 intubating them. Now we're going to bring that tone to 11. Really tight tone. And we're going to work with our respiratory therapists and our ICU colleagues to, our end goal, our end point is an I to E between 1 to 4, 1 to 6, ideally. You can keep them breathing relatively slowly, which to me, I have to always counter, right? Usually you intubate and you match is often the way I think about it. In these patients that are breathing really, really fast, it is okay to slow them down so that they have a nice long expiratory time. We can do that through an I time or an I flow, depending on your vent. Either way, our goal is to get that breath in really quickly so that they have a really long time to get it out. Now, you might get inspiratory pressure alarms, or tell me a little bit, Dr. Phillips, about what you're setting there so that you don't make alarms go off when you push all this air in really, really quickly and they have a high inspiratory pressure. What's the max you can allow an asthmatic to live at?
Great point. So, and a lot of folks, actually a lot of RTs are familiar with this as well. that peak pressure alarm on a ventilator is not just a, hey, maybe you want to take a look at it kind of alarm. It's actually not even just an alarm. All of the ventilators that I've ever seen, I've asked all the reps. So we're talking, Draeger, Hamilton, Vias, NK, all of them. And I'm just naming a few off the top of my head, right? Those are some major players in the ventilator arena. All of them, when you hit a peak pressure, whatever you set, it not only alarms, but it cuts off the breath. So it doesn't matter if you put in a tidal volume of 400. If you hit that peak pressure of oftentimes 35, 40 is what they set, then it's going to cut off the breath, and you're going to wind up with the hypercarbia that you were trying to avoid. So you have to increase that alarm setting. Now, that's tricky. That's only for the asthmatics. So you expect these to be high. So typically their peak pressures in a true status asthmaticus, those peak flow pressures will be like in the 80s, 90s, oftentimes, really high. But the key is that their plateau pressure, and I encourage listeners to check out that prior podcast that we did for peak versus plateau. No, that's a whole other conversation. Your plateau pressure should be low, and that's why we're not as worried about it. You have to change the peak pressure alarm to be high. I don't really care how high the peak pressure is, because it's just going to be. That's their physiology. Their plateau has to be below 30. Whatever you have to do on the alarm, you can set it to 90, you can set it to 100. It does not matter. Just watch out for that plateau.
Okay, super, super important and helpful there. So, one, if we hit that peak pressure cutoff set by the vent, and normally, 35, 40, somewhere around there, if we hit that in our asthmatic, which we'll hit fast probably, we're truncating the breath. So we're not actually giving very much tidal volume at all. We need to tick that up higher. And Dr. Phillips, I appreciate it. I think you have a no threshold, which I feel like I've heard in the past, some people be like, well, don't go too high on this. You're saying you can bring it up to 80, 90, 100. The peak pressure does not matter. The plateau pressure, that inspiratory pause plateau pressure, we will have reference in the show notes to our prior podcast, is very important. So you can
matters a lot.
Yes. Yeah, very important there. But we can set our peak alarm higher to make sure that we are delivering a tidal volume, checking our plateau pressures, but we'll get that air in really quickly. Of course, it'll come in under a pretty high pressure because we're forcing it in fast. We're going to not allow it to truncate. We're going to let them expire. Done right?
Yeah. Can I say exhale instead of expire?
You may. Yes, that's a good, poor choice of words. Now, a couple last thoughts, if I may. I know we're running a little late, but breath stacking and vent breaks. Do you find that if your person is paralyzed, hopefully they will not be stacking, and the whole taking them off the vent, pushing on the chest, getting the air out, how valuable is that? How often do you find that you have to do that?
I've only had to do that 2 patients I can recall, and I really had to do that. There's one in particular I'm thinking of during fellowship. I actually had to set my phone alarm every hour to go off. And whatever I was doing, I had to stop, go to his room, unplug the ventilator, push on the chest, tell everybody the alarm is me, right? So people don't freak out. Let them know, right? So unplug, and you disconnect at the level of the ET tube. There's the ET tube. There's a connector, little nubbin from the ET tube to your ventilator. You disconnect between the nubbin and the ventilator. And it's not chest compressions. You just lay your hands on either, basically over the pectoral muscle area, on each one. It's a slow and forceful push, and you're gonna hear the air come out. The reason to do that is if you just can't get around the breath stacking and their blood pressure suffers because of it. They increase their intrathoracic pressure so much that they can't get preload up into the heart. And that was what happened with this guy. We would see routinely his blood pressure was like in the 110s, 120s. And at the course of 60 minutes at the end of the hour, his blood pressure would be 80 over something. And I'd come in. It's an incredible feeling. I mean, I hope your listeners never have to do this. But their blood pressure is going down. The nurses are having to go up on the norepinephrine or whatever you have going on. So anyway, they have to go up on their pressors and inotropes. And you disconnect the tube, you press on the chest, and just the blood pressure rises. Yeah. It's an incredible sensation, and you feel like we talk about laying hands on surgical bellies and things like that, but you feel like you actually fixed your patient, not with these kind of intangible medications. You're like, you actually fix them with your hands.
Yeah, healing with
It's
the
neat.
power of touch. It is. I've had to do it once. It is remarkable, right? When you actually see their torso, they look like that expanded COPD chest, that big barrel chest, and you disconnect and it just slowly sinks down into the stretcher. You can hear it come out. And the reason you're saying to do that would be, we're doing our very best. We're trying to get that IE, ideally, 1 to 6 would be great. Say this person's challenging, they're very tight, we get to 1 to 3.5, 1 to 4, and over time you're starting to find, okay, blood pressure's dropping, starting to get more alarms. Disconnect them from the vent, press on the pectoralis, get that intrathoracic pressure down so that they can get some venous return.
Yep, and you can follow this. You'll know that they are breath stacking because their intrinsic PEEP will rise, and that is an expiratory hold. The plateau is an inspiratory hold.
Yep.
The intrinsic PEEP, your auto PEEP, is an expiratory hold, and you will see that rise more than like 3 to 4 centimeters of water is where you start to get concerned that's going to stack up.
Interesting. Okay. And so we're not doing just plateau pressures. We're not just doing inspiratory holds. We're doing expiratory holds. How often are you doing this type of physiologic check on the patient?
Initially, once every maybe 15 minutes, and then kind of an hour later, and just kind of see. You'll get a sense after intubating, you'll get a sense in the first 30, 45 minutes if this is going to go well or not.
Yeah. Okay. And so that sounds like, for me, that would be that, ICU doc at bedside or on consult. If they're tele ICU at this moment, you're going to be setting your settings with them for your, your I time or your I flow, trying to assess what your I to E ratio is. And then, at 15 minutes, you're going in and saying, all right, I checked my plateau. This is it. This is my expiratory hold. How we doing? You're going to be working with these colleagues on that because this is pretty complex stuff for sure.
Yeah, phone a friend.
Yeah. Awesome.
I was just saying thank you for letting me go over this topic. It's a good one. It's tricky, not very common, and satisfying when you make it work.
Yeah, absolutely. And thanks for your expertise on it. Again, it's like we said, sphincter tightening. You need to respect it, but not fear it. Have that line in the sand and cross it confidently when you do so. And of course, in the show notes, we'll have all this summarized. I will put together a little infographic that you can throw into your Evernote or peripheral brain so that you're thinking about these I to E ratios and your inspiratory and expiratory holds. These are things that are probably not going to live intrinsically in your brain, but you need to break out and be ready to and understand this with your ICU colleagues when you have this status asthmaticus. Okay, another great podcast in the bag. Thank you so much, Dr. Phillips. And as always, remember that SimKit is here for you for keeping up your skills in rare procedures. Let us do all the heavy lifting, all the planning, all the legwork, delivering procedures to your door so that you feel ready in these rare procedures that you just don't see commonly enough in clinical practice to keep up your skills. Click the link below for more.